The second part of this presentation on tracking the progress of the stroke survivor's recovery journey looks at the overall design of the proposed Stroke Quality of Life Survey. In particular, it explains why that survey should be based on the World Health Organization's International Classification of Functioning, Disability and Health, known more commonly as the ICF. The main design principles for the proposed Stroke Quality of Life Survey are that it ensures that the concerns of both stroke survivor and primary carer are monitored. This will ensure that any discrepancies between the concerns of the survivor and his or her primary carer are brought to the surface where they can be resolved before decisions are made to alter current treatments or initiate new treatments. It is based on the activity and participation section of the International Classification of Functioning, Disability and Health, or ICF framework, where disability items are directly related to one or more ICF codes. And because the ICF is an internationally recognised method of classifying abilities and therefore disabilities. Quality of life survey assessments should measure 4 things for each disability item. First, the level of concern about his or her capacity to perform a particular activity. Suggested choices and their scores could be unconcerned with a score of 0, minor concern with a score of 1, concerned with a score of 2, major concern with a score of 3, and extreme concern with a score of 4. Secondly, it should measure the perception of recent changes in his or her capacity to perform a particular activity. Suggested choices and scores could be major deterioration with a score of -2, minor deterioration with a score of -1, unchanged with a score of 0, minor improvement with a score of 1, and major improvement with a score of 2. Thirdly, it should measure the relative priority of actions to improve his or her capacity to perform a particular activity. Suggested choices and scores here could be no action with a score of 1, low priority with a score of 2, moderate priority with a score of 3, high priority with a score of 4, and urgent with a score of 5. Fourthly, the survey should measure any negative moods that are generated by a particular disability item. Of course, a disability may cause more than one negative moods, and suggested choices could be angry, anxious, ashamed, frustrated, isolated, sad, or okay. The survey should also be designed in a way that community-based service providers can easily match the services and programs they offer with specific disability items. Hence, they can be encouraged to register their capacity to offer specific services and programs to treat specific disability items. By getting the primary carer to complete the survey as well, the survey can identify differences between survivor and carer responses. This information may be significant in helping to develop and implement an effective community care plan. By completing the survey at frequent intervals, it will track changes in concerns, priorities, and attitudes over time. This will be important to the stroke survivor and carer because it will give them a feeling of their progress along the long recovery journey. The survey responses can be used to prepare 2 summary measures of the stroke survivor's quality of life. The first is what can be called a disability concern, which is calculated by summing the products of the scores given by the stroke survivor to the level of concern question and the relative priority question. So, if a stroke survivor is unconcerned about a particular disability, that will produce a disability concern value of 0. On the other hand, if a survivor has extreme concern about a particular disability and needs urgent action on it, that will produce a disability concern value of 20. The second measure is what can be called a recovery progress measure, which is calculated by summing the products of the scores given by the stroke survivor to the perceived change question and the relative priority question. So, if a stroke survivor is reporting a major deterioration in a particular disability item and needs urgent action on it, that will produce a recovery progress value of -10. On the other hand, if a stroke survivor is reporting a major improvement on a particular disability item, but still needs urgent action on it, that will produce a recovery progress value of +10. The recovery progress scores for individual disability items could then be summed to give an overall measure of recovery progress for a stroke survivor. The main aims of the Stroke Quality of Life Survey are to support the long-term tracking of the recovery of stroke survivors after their discharge from hospital and their return to their communities. The accumulation of a comprehensive stroke recovery database that is extremely useful for medical researchers, medical professionals, medical educators, service providers, and community healthcare administrators. And the planning and delivery of the kind of community-based stroke care services needed in all Australian communities. And the Stroke Quality of Life Survey should be based on the ICF framework because it focuses on the abilities and hence the kinds of physical, mental, cognitive, communication and behavioural disabilities experienced by stroke survivors. It correctly sees disabilities as both a medical and an environmental problem. It gives the survivor more control over his or her recovery by allowing them to determine what disabilities need to be worked on first, rather than just letting medical professionals control the recovery process. It covers a full range of possible stroke-related disabilities, including physical, mental, cognitive, mobility and communication disabilities, and personal, family, attitudinal, behavioural, social and community factors affecting recovery. It also groups disabilities into convenient sections that allow the Stroke Quality of Life Survey to focus only on those disabilities that are of concern to an individual stroke survivor. According to the World Health Organization, there are benefits of using the ICF framework for three important stakeholder groups. For individuals, the benefits come in the areas of assessment of individuals, allowing one to ask questions like, what is a person's level of functioning? Treatment planning, when asking questions like, what treatments can maximise functioning? Evaluation of treatments, when asking questions like, how useful were the interventions? Communication amongst health professionals and agencies. Self-evaluation by consumers, when asking questions like, how would I rate my capacity in mobility or communication? The benefits for institutions come in education and training, resource planning, when asking questions like, what healthcare services will be needed? Quality improvement, when asking questions like, how well do we serve our clients? Management outcomes, when asking questions like, how useful are the services we are providing? And healthcare delivery models, when asking questions like, how cost effective are the services we provide? And benefits for the society as a whole come in areas like eligibility criteria, when asking questions like, are eligibility criteria for disability pensions evidence-based? Social policy development, when asking questions like, will guaranteeing rights improve functioning at a societal level? Needs assessment, when asking questions like, what are the needs of people with various levels of disability? And environmental assessment, when asking questions like, how can we make built environments more accessible to all? So, by basing the Stroke Quality of Life survey on the ICF framework, the Stroke Quality of Life survey should also help achieve these benefits. But adopting the ICF framework has another great advantage in that it allows one to classify community care providers by the disability items, or ICF codes, they are qualified to treat. So the Stroke Rehab app can establish and maintain a comprehensive database where private and public sector service providers can nominate the disability items or ICF codes they are qualified to provide or that they have special expertise in providing. And by using a system of voluntary service provider registration, providers will only receive referrals through the Stroke Rehab app if they register to provide services for specific disability items and pay an annual registration fee that can be used to fund the national rollout and operation of the Stroke Rehab app. This registration can be done over the internet so that the administrative overhead of maintaining the services provider database can be minimised. Services providers would also be asked to identify what communities they offer particular services, be they local, regional, state or national. This services provider database will provide valuable and up-to-date information about service availability in metropolitan, regional and rural communities, service deficits in metropolitan, regional and rural communities, professional training needs, and recruitment programs for regional and rural communities. It also provides data for the preparation of comprehensive and up-to-date community-based stroke services directories in either hard copy format, as web documents or PDF documents, or as online directories. In part 2 of this presentation on tracking the stroke recovery journey, I have outlined the design principles behind the Stroke Quality of Life Survey, discussed the aims of the Stroke Quality of Life Survey, explained why the ICF framework has been chosen as the base on which the Stroke Quality of Life Survey is designed and built, outlined the potential benefits of basing the survey design on the ICF for individuals, institutions and society as a whole, and outlined how the ICF framework can be used to collect information about service providers in the community care sector. In part 3 of this presentation, I will talk about the procedures for completing the Stroke Quality of Life Survey, the Stroke Quality of Life Survey questions themselves, and the interpretation of the responses to the Stroke Quality of Life Survey.